Welcome to AJP Audio for May 2025. I'm Aaron Van Dorn. Today on the podcast, I spoke with Dr. Ken Ruggiero, a professor at the Medical University of South Carolina. Dr. Ruggiero and colleagues have a paper in the May issue of the journal, taking a look at the effectiveness of an app-based intervention at reducing the symptoms of sleeplessness and post-traumatic stress disorder in a broad cohort in the wake of a natural disaster. Afterwards, we'll again speak with AJP Editor-in-Chief Dr. Ned Kalin about the rest of the May issue, which looks at a wide range of issues surrounding treatment provision. Dr. Ruggiero, your trial took a look at the use of the mobile app Bounce Back Now as a large, cost-effective intervention for post-disaster mental health treatment. What can you tell us about the app and how it works and how it differs from the usual care in these circumstances?
The app actually consists of a variety of sort of brief interventions that are designed to help reduce distress in the moment, and also more intensive intervention components that are consistent with best practice treatments, but simplified so that users can sort of do it on their own. Usual care is a complicated thing in the post-disaster aftermath. There are best practice interventions for people who develop post-traumatic stress disorder and depression, but most people don't access it. So what usually happens in the aftermath of disasters is that a high number of people will develop significant symptoms. Most of them won't get help, and those who do get help hopefully will get best practice treatments. And so what the Bounce Back Now app is attempting to do essentially is bring it right to them, free of charge, bring the key intervention elements to them. What we see is that one of the reasons that people don't access interventions is because they have moderate levels of symptoms. They don't necessarily have full-blown PTSD or depression. And so they need some help, but they're not necessarily in a place where they're going to go get full-blown treatment. Or many patients or many individuals who want to get a little bit of help, they struggle to know exactly how to navigate the healthcare system. Many others may want to just sort of deal with their symptoms on their own, but they don't really know how. And so Bounce Back Now is really designed to give them a little bit of everything to help them sort of move the needle a little bit with regard to their symptoms, give them some things that will help to reduce distress in the moment, and also give them some strategies to help get best practice care if they need it. So that's where it differs from usual care. It just gives them additional resources to improve symptoms in the moment in a way that's free and easily accessible, and also guides them to treatment if they need it and have significant levels of symptoms.
So it's more like the opportunity for them to consider what's going on and to take a look at it and to have some access to resources and some simple, basic kind of self-guided considerations that might help in people who have experienced a traumatic event.
Exactly. And we even have a weekly checkup that helps them sort of gauge where their symptoms are in the moment and then check in once a week to see how that changes over time. And then the app gives them feedback based on what their trajectory is looking like and recommendations around what components of the app might be helpful and when to get help more formally.
So your study looked at the app Bounce Back Now, but it also looked at another simpler app that had a much more limited suite of things, offering more about information for who to contact if they wanted to. What did you find? Did you find that the intervention that you were looking at, Bounce Back Now, was superior to that simpler tranche?
We did. We looked at symptoms over a 12-month period among people who got the Bounce Back Now app and people who got the Enhanced Usual Care app. And what we found was that people who had the Bounce Back Now app did have a greater reduction in symptoms of PTSD, depression, and sleep disturbance, which was really encouraging. But another thing that we found is that even just for the Enhanced Usual Care app, which did have links to a whole bunch of resources that could be very helpful to people, that those adults also had a pretty significant reduction in symptoms. So while Bounce Back Now was better, the usual care option actually did fairly well, and it would have been very interesting to have a third group where they got nothing, which is actually more consistent with what happens in the real world after disaster, so that we could compare both of those conditions to the typical context.
So both of the apps did have a positive benefit, but the benefits were relatively mild.
Yeah, I would say so. I mean, there was a pretty decent effect, I think. It's just that when you compare the two groups, there wasn't a big difference. Bounce Back Now did outperform the control group, but not by a huge margin.
But certainly better than not having any intervention at all.
I would assume so, except we didn't have a group where they got no intervention at all, so we couldn't really track that. There is a group of folks after disasters who will have natural recovery of symptoms without intervention, but usually you see that in the first month after a disaster, and we didn't recruit people until 2 to 3 months after disasters. So I would assume that a lot of that natural recovery would have already happened.
Your trial looked specifically at people affected by natural disasters, in this case, hurricanes. Are there applications for this particular intervention in other instances of mass trauma, such as mass shootings and other acts of violence, or even more specific traumas for people who are at risk of PTSD, such as combat veterans, which might have a more specific individual circumstances, but is a much broader class?
The way that we design this is really to address situations where there are tens of thousands of people affected at any one time. A situation where the healthcare system would be overwhelmed, it's incapable of handling all of the mental health needs of a great number of people. And so, if we can reach tens of thousands of people at once with a free app and move the needle with regard to symptoms, that could have a huge population level impact, even though we might not be dramatically improving one individual's symptoms at a time. We may have modest improvements in symptoms, but at the population level, if we can reach a lot of people, then it can have big impact. With regard to, whether this is applicable beyond hurricane affected adults, absolutely. And in fact, after we completed the study, we refined some of the language to make it much, much broader than that. And it's not even just more broad in terms of any disaster affected population, it's really any trauma affected population. I had lots of people reach out to me while we were doing the study to ask about whether we could adapt it for, traumatic injury populations, or even people who were, experiencing lots of mental health symptoms relating to the COVID pandemic. There are lots of populations for whom this is relevant. It's especially, I think, helpful when you have large groups of people affected by an incident at a particular time. But we also plan to roll it out with our own traumatic injury population locally. Do I think that it would be an intervention that could stand alone? Maybe for people who had moderate levels of symptoms, but I would not advise somebody who had fully developed PTSD and depression for this to be their only option. It may be something that can help springboard things for them and accelerate recovery, but really just sort of a step in the process. So we are planning on rolling it out as a step in the process of providing care to traumatic injury patients who have behavioral health needs. Sort of a first step, and then people who have full-blown PTSD and depression would probably graduate to recommendations of getting a full dose of best practice treatment.
You've kind of touched on this in your last couple of answers, but the impacts of both the interventions were statistically similar. But the paper notes that since the cost of implementation is low, the modest effect sizes on mental health improvements could potentially justify a larger use of the intervention. Do you think there's a potential for a larger all in one digital intervention such as this one that could have a larger impact? Or will similar interventions remain an adjunct to more traditional methods providing mental health care in the wake of trauma?
It really depends on who we're talking about. As I mentioned earlier, if individuals have full blown PTSD and depression, I would graduate them immediately to best practice professional
Mhm.
care. I don't think an app is something that they would more regularly engage with enough that they would benefit at the same level that they would if they get treatment from a clinician directly. But I do think that there's a big place for resources like this to serve as a step in the process of stepped care approaches. I do think that they should be embedded within healthcare systems when possible, because I think that people will be more likely to access them if clinicians recommend or peers recommend that they use it, as opposed to the way that we reached out to people in the study, which was really sort of through social media, where a lot of folks might have some trust issues with that and not know whether what they're getting into and whether the quality is good.
What were the limitations of your research?
There were a few limitations. When we first designed the study, we had actually partnered with Red Cross and were planning on recruiting individuals on scene in the aftermath of disasters, in the immediate aftermath of disasters. But unfortunately, it didn't work out that way. Between the time that we wrote the grant and the time that we were awarded the grant and were ready to roll out the study, Red Cross had sort of redesigned themselves a little bit, and it was very difficult for us to partner with them at that level. And so we weren't able to work with them directly on scene, and instead had to shift to a social media recruitment approach, which is not ideal because you might be getting a slightly biased sample. People who are more affected by a disaster might gravitate to the study, whereas those who are unaffected may just sort of ignore the announcement to participate in the study. So you bias your sample a little bit. That is a limitation. We didn't include kids, which is a limitation, but I can speak to that if you have any questions about future directions, because we are going in that direction. One other thing, it's always nice to get in early
Mhm.
and be able to see where people's symptoms are in the first month after a disaster, because then you get a better sense for trajectory of recovery. In our case, we were usually 2 to 3 months after a disaster, partly because we had to we had to sort of design the sampling frame and get permission from NIH every time that we went into a new disaster affected population. And that was sort of a somewhat time consuming process to do that.
Did that lag in being able to get in and start interacting with populations that you were looking at with the intervention change how the intervention was designed and implemented?
We had originally planned on designing it slightly differently, but really only with regard to the weekly check-in. I mentioned the weekly check-in earlier. It's a symptom self-monitoring approach that helps people sort of see where they are and see how their symptoms are changing over time. We would have kept some of the more intensive components locked for the first month until we knew whether they had experienced full natural recovery. And then once we know at a 30-day period that they still have significant symptoms, then that would unlock some of the more intensive components. But because we recruited people 2 to 3 months post disaster, they were already past that watchful waiting period, as we call it. And so anybody who had significant levels of symptoms, that unlocked access to some of the more intensive components of the intervention.
What kind of uptake and interaction with the app did you see with populations? Was there any broad variability between the two arms that you looked at, and how many people were engaging with it regularly?
A very high percentage engaged with it regularly. I believe there were about 15 engagements per user in both conditions. It was a little bit higher in the bounce back now condition compared to the control condition.
Hmm.
One thing that we did notice is that people who engaged pretty frequently with the Bounce Back Now app tended to gravitate more toward those coping skills component, which are not particularly intensive. They're mostly geared toward reducing distress in the moment, as opposed to more long-term behavior change solutions. For example, things like breathing activities that are designed to reduce distress in the moment, or muscle relaxation. For the more intensive elements, I realize I hadn't really said anything about that in this interview, but the more intensive elements, examples of that include things like writing exposure, where you write about what happened and how it unfolded, and it's meant to sort of break patterns of avoidance and help you to process what occurred a little bit more deeply. The behavioral activation is a really tried and true, effective, simple strategy for depression. And so that involves the sort of reconnection with your values and aligning activities that you schedule with those values, and basically scheduling them and following through with them. So behavioral activation is the scheduling and completion of more fun and functional activities, which of course it makes sense that the goal of that would be to reduce depressed mood.
For the writing exercises you just mentioned, is that something that your clinicians were taking a look at, or is that more of a self-guided journaling exercise?
It was self-guided in this case, where they were encouraged to write for 30 minutes
Hmm.
once a week for 5 weeks.
That's a significant amount of time
It
for
is.
someone who stares at the blank page. So you mentioned earlier future directions, but what's next for your research?
A few things. One, we're working on a Bounce Back Now app for teens. It's actually not being done in the context of a research study. It's being done with SAMHSA funding under a services grant. One of our prior trials was actually done with teens on a web-based platform, and we found that it was effective in reducing symptoms of PTSD and depression, similar to this study, compared to a control group. And so now we need to redesign that for apps for mobile health. So we're in the process of doing that right now. It's pretty vignette heavy and sort of peer heavy in terms of the education that we're giving to teenage users, but that's something that we're looking to roll out soon. Another big next step for our research in this field is we've adapted Bounce Back Now already to be more broadly applicable, as I mentioned, to trauma affected populations. We do a lot of work with traumatic injury patients, people who experience bad car crashes, motorcycle crashes, gunshot wounds, and have very high risk for development of PTSD and depression. We already have a model of care, but it doesn't include an app like this. And we are looking to embed it within our stepped care model and seeing whether that improves uptake of later care for those who need it.
Well, Dr. Ruggiero, thank you for taking the time to speak with us today.
Thank you. Appreciate your time.
Up next, Dr. Ned Kalin. Dr. Kalin, welcome back to AJP Audio for May 2025.
Thank you, Aaron. It's a pleasure to be here.
Today on the podcast, I spoke with Dr. Kenneth Ruggiero, discussing their paper looking at the use of a mobile app to address mental health distress in a broad population following a natural disaster. What can you tell us about it?
Yeah, this is a really interesting paper, Aaron, that focused on using an app called Bounce Back Now, which is an app that was developed earlier on and was shown to be somewhat useful in adolescents that were exposed to disasters. And in this case, it was tested in U.S. adults that had been exposed to some of the severe hurricanes in 2017 and 2018. Basically, what the investigators did is that they had a sample of about 1,357 adults that were living in these areas. And they split these individuals into two groups. One received this digital mobile app, Bounce Back Now, and the other received something that was called enhanced usual care. So that was the comparator for Bounce Back Now. Bounce Back Now really is something that was designed to get at some symptoms, specific symptoms. It provides psychoeducation. It tries to help with coping strategies, works on some PTSD symptoms, decreasing negative mood, and also improving sleep. So there's sort of a focus on these different symptoms that you might expect to occur after a disaster, in this case, after the severe hurricane exposure. And also there's a educational component to this, which provides access and information about how to get resources that are related to disasters and also mental health resources. The comparator, which was this enhanced usual care, did not have any of those other ingredients, but just had the links to disaster and mental health resources.
Mm-hmm.
So what they did is they provided these two different apps and followed individuals for up to 12 months and assessed them at 3, 6, and 12 months. And obviously the hope was that this Bounce Back Now intervention would greatly reduce symptoms and also PTSD types of things, including, PTSD symptoms, depressive symptoms, sleep symptoms, and so on. And what they found was relatively weak effects that were suggestive that Bounce Back Now is effective, but the effects were not overwhelming. So the Bounce Back Now participants had a greater decrease in depressive symptoms at 3 months compared to the other enhanced usual care participants. But for example, this difference was not apparent at the later time point. So it looked like that was sort of a short-lived difference between the two interventions. There were, again, Bounce Back Now also had greater reductions in sleep symptoms. They were evident over the first 6 months, but then later on, that those differences were not apparent between the two groups. Both groups, both interventions, had minimal decreases in PTSD symptoms, with some hint that was greater in the Bounce Back Now group. So overall, this was a trial using advanced technology to try to get at large populations that are vulnerable from a disaster. But I would say that the results were in the right direction, but certainly not strong results. But I think the importance of this study is thinking about how this type of app or others can be improved upon. Clearly, the strategy, the technology, the ability to get something out that can help people with their mental health and help them cope during a disaster to large populations has obvious advantages if it can be optimized and if it can really become effective. It also may be that the components that have to do with getting resources were really critical because that's what the other group had, and also there was some improvement there.
Since provider access is a persistent issue with provision of mental health care in the United States, is there potential for these kinds of broad-based, relatively mild effect interventions to be able to be applied more broadly?
I think there is. I mean, I think that, we are seeing now a whole emergence of various digital applications of trying to improve mental health and well-being and build resilience.
Mm-hmm.
For sure, the most vulnerable populations would be the populations where you would want to apply that initially. But I think as we see the technologies develop and develop an evidence base to test them, we're going to see more and more opportunities for these types of technologies and available applications from the standpoint of improving mental health.
Next, we have a paper from Norman and colleagues, which is an RCT taking a look at prolonged exposure therapy with and without topiramate in patients with comorbid alcohol use disorder and PTSD.
PTSD is commonly associated with substance use problems. Alcohol is certainly one of them. It should be noted that when PTSD is associated with substance use, it makes it all the more difficult to treat and to treat both of these. And there have been a variety of studies that have tried to tackle this problem, some treating one and then the other and so on. But in this randomized double-blind trial, explored the possibility that combining prolonged exposure therapy, which is an evidence-based effective therapy for PTSD, with topiramate, that would be more effective than prolonged exposure therapy alone, or in this case, plus placebo as a comparator, for the comorbid symptoms and treating the comorbid symptoms of PTSD and alcohol use disorder. In this case, the study group was a relatively small group. It looked at 100 veterans with PTSD. Some of them may have had subthreshold PTSD symptoms, and they all had comorbid alcohol use disorder. They were randomized into two groups, and each group was 16 weeks of treatment. They got 12 sessions of prolonged exposure therapy over a 16-week period. The topiramate group also got 16 weeks of topiramate that was titrated over 5 weeks from 50 milligrams per day up to 250 milligrams per day as tolerated. The other group got the prolonged exposure therapy and then got the placebo for 16 weeks. Primary outcome measures were looking at the percent of heavy drinking days, the reduction in the heavy drinking days. And in this case, for men, that was considered to be 5 drinks per day, and for women, it was 4 drinks per day, and also PTSD symptoms. Now, one of the things to note, and it's not clear why this was the case, is that there was considerable dropout in this study. Roughly 60% of the participants in the topiramate and 48% of the participants in the placebo group did not complete the study. So we already started with a relatively small n, 50 in each group, and you're seeing that around 50% are dropping out. So right away, when you think about a treatment that's going to be useful, you want a treatment where you're not going to see this level of dropout. It's not clear why this was the case in this particular study. They found that the percent of heavy drinking days and percent of days abstinent decreased significantly in both groups, with no significant difference between the treatments. So from the standpoint of effects on substance use or alcohol use disorder, both treatments seemed to be helpful, and topiramate did not look significantly better. PTSD symptoms, however, decreased in both groups, but at the end of the study, it turned out that the prolonged exposure in topiramate group had significantly greater gains than the prolonged exposure group with placebo. Now, this was not totally expected. I think it was expected that both comorbid types of symptoms would decrease, but particularly it was expected that topiramate would enhance the reduction in alcohol-related symptoms. But here it looks like it actually enhanced the reduction in PTSD symptoms. So as an example, when looking at one of the usual scales, the CAPS scale, went from 36.7 at baseline to 20.8 in the topiramate group. And in the group with placebo, it went from 38.6 to 29.9, or close to 30. That was good news. The news that wasn't so good is that the difference between the groups, or the advantage of topiramate, was not evident when these patients were followed up at 3 and 6 months. So again, I think there's promise here from the standpoint of adding topiramate. It looked like at the end of the study, which was 16 weeks, there were gains in PTSD symptoms as compared to prolonged exposure therapy, which in and of itself is an effective therapy. And it did not look like there were significant advantages to using topiramate in relation to the comorbid alcohol use disorder symptoms, at least as measured by heavy drinking days.
Following that, we have a paper from Conrad and colleagues looking at 5-year outcomes from a school-based, personality-focused substance use prevention program.
Yeah, this is, I think, a really interesting study and has findings that are pretty dramatic. And what these investigators did, and this was done in Canada, in Montreal schools from 2012 to 2013, is that they took 7th graders who were enrolled in the schools, and they gave them a battery of tests that looked at various traits that, when excessive, are risk factors for developing substance use problems. And so, for example, traits related to impulsivity, sensation seeking, anxiety sensitivity, and hopelessness. And the reason they were interested in these traits is that these traits, again, when extreme or more excessive, have been linked to substance use or vulnerability to substance use. And there have been some specific linkages. So, for example, individuals that tend to be more extreme in the impulsivity range tend to like stimulants, whereas individuals that are more anxiety sensitive and have more depressive types of traits tend to be more interested in sedating agents, and such as alcohol, sedatives, and opiates. Anyway, what they did is they took the 7th graders, they administered these tests, and then they took the individuals that were more extreme. They had to be 1 standard deviation greater than the mean in these measures. When they did that, they basically came up with a group of roughly 1,600 individuals, and 705 of them received this brief intervention, and another roughly 900 did not receive any intervention at all as the comparator group. What was most impressive is that the intervention was tailored to that individual's specific traits. So if you had impulsivity traits, some of the intervention was aimed at trying to help cope with those types of traits and manage those traits, as an example. And there were only two 90-minute sessions that each individual got. So, very brief, relatively short, efficient interventions focused on the traits and the maladaptive behaviors that are associated with those traits and that could lead to using substances. They followed these individuals over 5 years, and the data that they used was self-report data on how much they were using substances. And also they collected psychiatric symptom data as well that was self-report. So that's an issue. I mean, when you get self-report data, one has to question sort of the validity of that data. It's not saying that it's not useful or good, but it's a bit of an issue. Anyway, long story short, they found that in the intervention group, there was a 35% reduction in the reporting of the development of substance use problems and disorders over each year of follow-up as compared to the group that did not get this intervention. In fact, the group that didn't get the intervention had a significant increase in substance use problems. So this looks quite promising. I really like this paper because it's a brief intervention. It makes sense to sort of identify high school kids at risk and also to tailor the intervention a bit for the type of traits that may confer the risk that individual has. And it looks like in this case, the intervention was quite effective. So efficient, sort of cost effective with a really nice result. So I think this really warrants further investigation.
You mentioned the need to be cautious with self-reported data like this, but I was wondering, are there any known issues with self-report, especially when you're talking with children, teenagers, talking to people in authority?
I think that can be an issue. I mean, I think that these were probably scales that were filled out, so it wasn't direct interactions. The data was probably anonymized, but still, those are issues. I think that you can imagine the incentives to perhaps underreport about, engaging in behaviors that
Sure.
are not seen as acceptable from a societal standpoint.
Or even over-report.
Either way. So, but again, I mean, a lot of the measures that we get from our studies are self-report measures. So I'm
Sure.
not totally being negative about that, but they weren't measures that were interview measures or measures that were obtained by clinicians, or for example.
Next, we have an article by Olfson and colleagues looking at psychotherapy trends in the U.S. straddling the pandemic era.
It's an interesting paper. It looks at characterizing the utilization of outpatient psychotherapy in adults in the United States from 2018 to 2021. So, sort of as you mentioned, straddling the COVID era. The way that this data was collected, it was collected from a standard household survey that is called the Medical Expenditure Panel Survey. In this survey, participants are asked questions about their medical care, including their mental health care. What the investigators did is they used this database. And one thing to keep in mind is that when they looked at a mental health visit, it was defined in this study as receiving a mental health diagnosis, regardless of the type of diagnosis or whoever provided the service. Okay. So it's not necessarily as we might think of a mental health visit. It's when you go to a doctor and you receive that diagnosis. Okay. What's interesting though is from this time period from 2018 to 2021, there was an estimated increase in individuals that received treatment for a mental health problem or condition. It went from 28 to 32 million from the standpoint of U.S. adults. When they specifically looked at psychotherapy, which was their major focus, they found that there was a very small increase in the number of adults that reported receiving psychotherapy, and this increased by about 2% over this time period. And interestingly enough, the number that they report is about 22 million individuals received some form of psychotherapy in 2021 as an example. So pretty high number. But even though there was a slight increase, importantly, the authors point out that there were decreases in the number of psychotherapy visits that were characterized in individuals that were financially disadvantaged, including those individuals that had public insurance. Also, in addition to that, there was a change in who was actually administering the psychotherapy. And we've sort of seen this before in some other work that's been done, but there were decreases in the numbers of psychiatrists and psychologists that were providing psychotherapy and increases in the numbers of social workers and counselors. Now, this is not necessarily a bad thing at all. It's just a shift, I think, in the trends from the standpoint of who's actually doing the psychotherapy work. In 2021, approximately one third of the patients had at least one psychotherapy visit with a psychiatrist. And for all patients that received psychotherapy, regardless of who was doing the treatment, the average number of visits was about 11.8. Roughly 60% of those patients also receiving psychiatric medications or psychopharmacological medications. And the most prescribed medications were antidepressants in this group. 49% received antidepressants, and about 20% received anti-anxiety drugs or sleep-related medicines. The other thing that was interesting is that when they looked at the percent of psychotherapy patients that were prescribed stimulants, this actually increased from 2018 to 2021. Again, not a large increase, but it increased from 11.6% to 12.2%. So this is simply a study that characterizes the trends and changes in psychotherapy and also the amount of psychotherapy. I think it's interesting from the standpoint of the numbers that we see. I think an important takeaway is the reduction in psychotherapy visits that were experienced by disadvantaged and marginalized individuals, and also the trend from the standpoint of the psychotherapy shifting over this period of time to more of it being performed by counselors and social workers as compared to psychiatrists and psychologists.
And finally, we have a priority data letter also from Dr. Olfson and another set of colleagues looking at the use of telemental health care in children and adolescents in the U.S.
This is another sort of a characterization paper from the standpoint of the utilization of telemental health. One of the outcomes, I think, or the silver linings of the COVID epidemic was our opportunities to use more innovative strategies for healthcare, which in this case was telemental health. Telemental health and telehealth had been around prior to that, but clearly because of the limitations that we all had with COVID-19, especially earlier on, the opportunities to use telemental health really came to the fore and were unfortunately utilized. The advantages of telemental health strategy are obvious. It's an opportunity to meet people where they're at. They don't necessarily have to come into a site to be seen. Opportunities to reach larger swaths of the population, especially in areas where there are not available resources. So great opportunities. On the other hand, we have also been aware of some of the potential disadvantages, including not individuals who don't have the means, not having the technologies, not being individuals that are living in impoverished areas, perhaps not having the internet capabilities, and so on. So you can imagine the possibilities for great, expansion for public health, as well as at the same time potential inequities that could occur. So that was sort of what this group looked at, and they looked at the utilization of telemental health care in U.S. children and adolescents, in this case in 2021. So at sort of towards the end of the pandemic. They looked at the utilization of in-person visits. They looked at the utilization of telephone and video visits. And importantly, as I mentioned, they focused on these in relation to various socio-demographic variables. They utilized a sample of roughly 2,500 families that they demonstrated or at least thought were representative of the population. So that's one thing to keep in mind here. This is not a huge number of individuals. It's a smaller sample actually from this thing that I referred to before, the medical expenditure panel survey, that was thought to be representative families of a national sample. And what they found was that in 2021, they estimated that 13% of youth received any mental health treatment. And roughly 53% of these individuals were seen for all their visits by a mental health provider. 31% of outpatient treated youth had at least one video visit. Interestingly enough, girls were more likely to receive a video visit than boys. I have no idea why that would be the case. And also, youth that were living in more urban areas were more likely to utilize video visits than individuals living in rural areas. In contrast to these findings, and maybe not totally unexpectedly, there was a decreased likelihood of receiving a video visit for youth from lower income families and also in non-Hispanic Black individuals and in individuals with public insurance. So this underscores, I think, both the advantages and potential disadvantages of these types of strategies. I think, again, just to emphasize, I think we've learned from COVID-19 the opportunities and advantages of telehealth. It's clearly being utilized much more now than it was before. It's got its advantages, but also I think we have to keep in mind of the potential inequities that this type of strategy can also confer, and think about how we need to address that.
The future's here, but it's unevenly distributed.
Exactly.
Dr. Kalin, thank you for taking the time to speak with us today.
You're welcome. It's a pleasure, Aaron.
That's all for this month's AJP Audio, but check out the other podcasts on offer from the APA, including Psychiatric Services from Pages to Practice. In their most recent episode, Dr. Dixon and Dr. Berzin talk with Dr. Judith Cook about a randomized controlled trial of an intervention designed to improve the financial literacy and wellness among people receiving treatment for mental health conditions. That and more can be found at psychiatryonline.org or wherever you get podcasts. The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you're having a medical emergency, please contact your local emergency response number.